Thank you, Christian. Greetings to Roman, Jolie, and all the others. I'll start sharing my screen. Do you know? Do you see my screen now, please?
Yes, everything is set up now.
Okay, perfect. So, my task is to speak to you about the question of fluid management in not only to fluid management in critical care. Regarding this topic, I have to admit there are some conflicts of interest, but most of all is that I believe that monitoring hemodynamics is an important part of our daily routine. When talking about fluids in critical care, first of all, we should first ask the question why we give fluid. And I will then later on speak about Phoenicia trial once more. But several years ago, it was published 2015, there was a multinational observational trial called Phoenicia. And one of the questions the physicians were asked was, what was the reason they administer fluid? And if you look on all these hypertension, weaning vasopressors, etc., you can translate it to expanding circulating blood volume, hence increasing venous return, hence increasing cardiac output, hence improving peripheral perfusion. These are the necessary steps on the line why we give fluid to our patient. So that's why. And now the question, how much? Uh, in few years from now, in the 30s, it will be 200 years jubileum. We are using intravenous fluids. That's not that well known, but the first who administered intravenous fluid was Thomas Latta during the London cholera or British cholera pandemics. And at that moment, he actually postulated that this is a life-saving treatment, but when judiciously applied, it will be the most powerful and one of the safest remedies. So this is almost 200 years ago. If you will type fluid therapy in PubMed, nowadays you will more or less see more of articles like this one, that you get fluid accumulation syndrome, that the critical care fluid accumulation and fluid balance are important factors. So over these 200 years, we've expanded our knowledge. And today we more speak about let's say, the dark side of fluids. We speak about edema, interstitial edema. We speak about the effects on fluid accumulation, and fluid accumulation syndrome is a relevant topic in intensive care. But we should never forget that in the beginning of fluid therapy was the opposite, was dehydration, was low perfusion, uh, oliguria, and all the other sides of not having fluid therapy. So when we're talking about how much fluids, we started to rely on this so-called Bellamy U-shaped curve, and we are trying to hit the sweet spot. So somewhere between the scilla and charybdis, between the hypovolemia induced complications and hypervolemia induced complications. But not only patient and patient are different. We are talking about individualized care. If you will look into data, and these are peri-op data, this is not aseptic cases, these are peri-op data, and just taking a lot of patients together, and a lot of patients stratified based on the amount of fluid they received in the perioperative period, and what was the hazard ratio of mortality. And you see that really, if they were somewhere in the middle, they were on the sweet spot. But when you look into complications, you will see that the sweet spot for lung was on other side and the sweet spot for kidney. So it's not only patient to patient, it's also organ to organ. Each of these needs slightly different perfusion, slightly different approach. So how much fluid we need during sepsis/resuscitation? What's different in sepsis and, for instance, the peri-op period? So first of all, we know that the vascular barrier in sepsis is disturbed. There is a layer on an endothelium called endothelial glycocalyx, and we know this is disrupted during the during the systemic inflammation. So sepsis and trauma, both of them, they will destroy the endothelial glycocalyx. So the vascular content is decreasing because of the damaged vascular barrier. So everything what we give into the plasma volume in order to expand the plasma volume will necessarily go into interstitium, and from on they will go to interstitial space. So this is the reason for the edema. And from the peri-op setting, we don't have these data in the sepsis, but from peri-op setting, we know that if you give fluids to your patient, a marked molecules of water, the patient gets rid of this water within 20 minutes, but up to 6 hours. So it takes a time, and half-life of the water injected of the fluids injected is basically very long, 6 hours. But if you look on the volume effect of the fluid, it's much shorter. It's 20 minutes or maximum. So here you have a disproportion between the treatment effect and the side effect, the disadvantage of fluids, the accumulation. So if you would like to expand, you will have to give more. Some decades previously, we've been used to it. We've been told by our teachers that the patient has to swell to be well. A septic patient with a positive cumulative balance was something like a fashion. It was normal. So we've been accepting this. And for instance, the reverse optimization, the reverse early go down to therapy published on the break of the millennium was one of the markers of this resuscitation target. Afterward, we got the promise to erase the process. I sometimes say this was really like the book by Franz Kafka from Czech Republic, like it was in a process. But honestly speaking, this was the wind of change between the swell and the current contemporary approach. If you will compare the population published by Rivers and the amount of fluids administered into Rivers population, not only the EGDT, but also the controls, and the amount of fluids administered to the other in the other septic trials, it is one half. It is 4 liters to 2 liters. We are changing a paradigm. And we know from multiple studies, I've just picked one, that increasing the positive fluid balance over the years, 1 day or 3, further on, the mortality risk rises. So trying to allocate another sort of treatment, another possibility to treat that the vascular content is decreased, is the fact that sepsis is also associated with a decreased vascular tone. So we can use vasoactive medication, and Zoli will talk about, in order to reduce, to increase the vascular tone, and hence help to mobilize fluids within the body and to use less resuscitative fluids. And again, we've got some data that use of norepinephrine plus fluids leads to a lower amount of fluids administered during the sepsis treatment. And this may be a way to go. And in addition, when I spoke about fluids and the effect time to the stay time or to the half-life, it's important to know that the effect time of norepinephrine is within minutes and the half-life of norepinephrine is within minutes. So there is an immediate effect on and off, not like fluid. So that's, from this point of view, it's possibly a wise idea. So if we will go with the fashion, we may shift from the swell to well to the dry side to keep the patient dry, unless the family will cry. We are somewhere in the middle. If you will look on the pendulum swinging there and back, it's like the Bellamy curve. Okay, it will be better to stay somewhere in between. So what's the most recent data on the fluid therapy in septic patients? So we have to look into the classic trial, for instance. This was a 70 and 70 randomized trial, and comparing liberal or standard and restrictive group in fluid resuscitation with no outcome benefit, and or with no outcome change. That's important to say. But if you will go into the data from classic trial, there are several points we should discuss. First of all, into classic trial, which tried to compare a fluid management in sepsis, in early sepsis, the patient had received 3 liters before being randomized. If you will look into the amount of fluids which were administered in the restrictive and standard care, they do differ as in the mean differs. But if you compare the spans, then you see that almost half of the patients in the restrictive part received more fluid than those in the standard. So we don't have a good stratification, not even in IV fluid volume or cumulative fluid volume. And the most important information coming from this trial is that the total fluid volume received within 5 days in both groups was almost 10 liters. And that actually the amount of resuscitative fluid was basically 1/4. And this is further supported by another data. Amount of resuscitative fluid is a small part. It's only a small part of fluid the patients received within the first days and not later anymore. So if I should translate the data from the classic trial into the concept of arose, that we have a time escalation of therapy, resuscitation phase, then optimization in the ICU, stabilization, and further on, we have to admit that classic trial is not answering us the problem of resuscitation, not at all. It started three liters after. So that's a trial for the optimization stabilization phase. It's a pragmatic trial. And from the pragmatic point of view, it seems it doesn't matter how much fluids the patient received. But the most important part is that the problem, especially in these later stages, is elsewhere. The problem of fluid accumulation is not resuscitative fluids. That's the bias flow we give to our patients with nutrition, with pharmacotherapy, or creep fluid or whatever. Okay, so what else do we have in the literature? There is another Glower's American trial. Here again, restrictive and liberal fluid strategy again, and here you can see that the separation between the groups were much better than in the classic trial. So this is really restrictive and liberal. And you see also that the early administration of vasopressors was more pronounced in this trial. So, okay, here you got the group separation. But again, no outcome difference, first of all, and the authors self-admit this is not the resuscitative phase. That's the phase 24 hours after. These are patients who receive 2 liters in advance to get into the trial. So we got the same information from classic and from Klaus. In pragmatic trials, doesn't seem much. But what to do with the resuscitation phase? Okay, we have to admit that these 2 liters are not in the hands of intensivists. Do you remember George Clooney's series in TV series? It was emergency department series. And these 2-3 liters, we have to admit that the resuscitation phase is not in hands of intensivists. It's in the hand of emergency physician doctors or nurses. So if you will look into the data, what happens in there, there are several studies aiming on this. Of course, they are not randomized. It's very difficult to randomize sepsis at the very, very beginning. But what we know from observational trials, and basically not a small ones, 1,300 in the CEMER trial, for instance, those who received fluids as a septic resuscitation, on the last bar, the mortality is strikingly lower than those who received no fluids during the stay in the emergency department or pre-hospitally. And the same is from the French trial. You see that those infused 10 ml per kilogram were much higher risk of death than those receiving 20 ml per kilogram. And in this JAMA paper, again, observational, patients who were hypotensive and received fluid resuscitation prior admission to intensive care were much lower risk of mortality. So it seems to be okay during the resuscitation phase to receive at least 2 cc's per kilogram. Maybe the guidelines telling us 30 mLs in 3 hours are right, but intensivists should not read them. Emergency physicians should read them, and intensivists should not, because it does not link to them. And if you will go into the meta-analysis of all the data, or the analysis of fluid balance within the data, you see that these 2 liters are possibly translated into benefit even in these studies demonstrating an harm of positive fluid balance. But back to one more point, and this is the pragmatic trials, and what the pragmatic trials are able to tell us about the fluid management in early sepsis. If you will just think about what pragmatic means, pragmatic is do what you are usually doing in these patients. No protocol, no try to individualize, just do it. And what we are doing, okay, data from 2015, but if we asked intensivists in 2015 how they pragmatically do fluid therapy, for instance, how they base the decision to give fluids, then mostly it was nothing. CVP, that's the pragmatic design. And further on, those who tested fluid responsiveness and the test of fluid responsiveness was negative, still in half of the cases they gave fluid. So, okay, no, don't give fluid, the patient's not fluid responsive, but still the fluid was given. So this is the pragmatic design. So we should not be, let's say, surprised that the pragmatic design is not telling us any answers. This is the design of the pragmatic trials. And you can pragmatically say that even in the recent Andromeda 2, I will hit the Andromeda 2 trial once more. In the Andromeda shock trial, sorry, by Glenn Hernandez, the fluid responsiveness disappeared over the trial. Yeah, naturally it disappeared because the patients were fluid resuscitated. And if you are giving fluid to patients who are fluid responsive, they will develop fluid unresponsiveness. So it's just a pragmatic description of the case. So how to do? We have to admit that the patients are different. When we are treating sepsis, we should look more into detail what sort of patients we are treating and what is the source of sepsis. And peritonitis will never be the same as pneumonia or meningococcal sepsis. There are data even from the emergency department. The hemodynamic pattern of our patients is strikingly different, either using non-invasive technologies or using echo. Just looking at the ejection fraction and VGI, you can separate your patient in those needing fluid and those not needing fluid. And if you would like to aim your therapy on something very easy to get, even in the emergency or in the first hours of your ICU stay, when you don't have fancy machines, you can use the CRT, the capillary refill time, which is one of the important old to new broad decision-making tools published by Andromeda trial. And I'm really convinced that this is a way much faster to allocate a fluid responsive patient. So to answer the Zolli question, how much fluid do we need? Honestly speaking, I don't know because it's individual. I can't give you a recipe. But me, when treating a patient, if my septic patient have received half a liter up to 1.5 liter balanced crystallite during the transport and during the stay in the emergency department, I'm pretty satisfied. If the norepinephrine is started in a septic patient during the ED stay and he is still hypoperfused, okay, then I will ask if I have the echo signs of fluid responsiveness, if he has the CRT prolonged, if he seems fluid responsive, I don't bother giving another 500 guided by response on CRT, guided by response on echo, and another 500 mLs. So up to the 30 cc's within the first 3 hours, I don't bother. But after this amount, if the patient needs more, then I am really restrictive. I really want to know more. If he's still hypoperfused after the first bolus, I give fluids only in the state when he is really fluid responsive and potentially and optimally if he is on high norepinephrine guided by hemodynamic monitoring. So, I thank you for your attention. I hope we will stay friends with intravenous fluids. And all of you, I invite to be part of the next Fenice. I told you about the Fenice trial first, published 2015, and we are now with the CD section redoing the trial. So it's an observational trial, how the fluids are used today. So thank you for your attention, and that's everything from Pilsen. Greetings.
Thank you very much, Jan. It was a very exciting presentation, and I would like to say that Jan is the president of the CEFSTIST as well. I'm sorry, Jan, I forgot to mention it at the beginning. And I will open the discussion yet because Professor Benes needs to go. So if everyone has any question, please do not hesitate it. Meanwhile, I have a question, Ian. You mentioned at the beginning of your presentation the problems with the barrier function of the vessels in septic patients. And my question is whether if you have a patient who is fluid responsive and eco positive as well, do you use albumin solution during the fluid resuscitation phase? And is there any evidence of efficacy of albumin solution versus crystalloids? And my second question is, what do you think about that? Should we use fresh frozen plasma in that case when our patient has a very severe capillary leakage due to inflammation?
Oh, thank you. Great questions. Great question. Basically, both of them aiming on restoring the glycocalyx.
Yes.
Oh, first of all, I will start from the other way around. In the first condition of repairing the glycocalyx is to stop the destruction. Mm-hmm. So first, what you should aim is to stop the inflammation with antibiotics, remove the source and source control and everything. This is the condition number one. Then, in order to let's say restore the glycocalyx, we've got laboratory data. We have very sparse data from, for instance, in vivo microscopy studies, or that potentially albumin may be able to restore. But the case is that usually it's not the matter. The glycocalyx layer is done or is like mechanically. These are the heparan sulfate and other molecules coupled or connected into the glycosaminoglycans coupled into the endothelium. And between these glycosaminoglycans, there is the oncotic proteins, mostly albumin, and this helps in the structure. And the case is if you destroy the structure holding the albumin and you don't rebuild it, then the albumin doesn't make sense because it will just flash away. So first of all, you have to restore the glycosaminoglycans and proteoglycans, and this structure has to be built anew by the endothelial cells. And then it makes sense to give proteins to expand the glycocalyx layer. So that's important point in there. But what we know that from this lab data, sometimes it may work administering albumin, or I know that there are some data, for instance, from big OPs, from thoracoabdominal aneurysms, that they are using this solvent detergent plasma, better than the plasma itself, the solvent detergent plasma, to restore it seems that they do restore the glycocalyx layer. But clinically, as a clinical evidence, enabling us to do this for real we are missing. Okay, so that's a concept, maybe supported by some small evidence data or low evidence data, but a concept which has a rational, but as I spoke before, the glycosaminoglycans are not standing there. So that's the reason. Honestly speaking, we use albumin for the 20% albumin during sepsis management, sepsis fluid management, but not as a first line treatment. And we start to consider it within the day 1 or 2 in those who are really fluid dependent, fluid responsive, and they got a high risk of leakage. And usually these are people who are on PICO device. So we see that they got, for instance, high extravascular lung water, high PVPI. So we see that the leakage would be potentially more pronounced. So we then use the 20% albumin, which we hope will have a higher volume effect in comparison to the amount of actual water given to the patient.
Super, thank you very much. Do you have any question? Yes? Professor Molnar.
Hi, Jan. Good to see you. It's a pity you're not
hi,
here.
I don't see you. Sorry.
You can't see me. Well, I'm in good shape. Don't worry. Don't worry. So we published a very nice paper together, you and me and Bernd, titled Multimodal, Individualized, Contextualized Hemodynamic Management. So can you share a few words on what does that mean? Because I think for me, it is the most, there are two difficult questions to answer at the bedside every day. One is to give or not to give fluid, and the other one, does the patient have infection or not? So obviously just focus on fluid. So I was missing from your talk SCVO2, CO2 gap, lactate, blah, blah, blah.
Oh, okay. I knew that I got only 15 minutes and I made it 20. So sorry. No, you're definitely right. We should never treat one thing only. It has to be in context. And for instance, in here, that the patient is fluid responsive doesn't mean he needs fluid. As I had on the first slide, we are actually giving fluid to expand the circulating blood volume, to increase venous return, and we hope that the fluid we give into the patient will increase venous return, but it's not necessarily the case. When you got sepsis, the fluid may leak away and it won't increase venous return. Increasing venous return doesn't mean that we are actually increasing cardiac output, which is the second step in this. Maybe the heart is in a failure, or there is a right-sided failure induced by ventilation, by positive pressure ventilation, and it will just increase the filling pressures and just increase the leakage. And we can go further on. Increasing cardiac output doesn't mean that we increase peripheral perfusion. So these everything is there in the line I have to consider before administering fluids, because it will be very difficult for me to remove the fluids afterwards. And this is exactly as you just meant, and this is the part of the article we've published together. So it's not only fluid irresponsiveness, it's not only giving half a liter of something into the body, it's also considering all the parameters on the way. Maybe you should consider CVP as a marker of not only of the preload, but of the preload capacity or venous return of the body. You should consider cardiac or VTI or cardiac output of the body. You should consider the oxygen delivery, so hemoglobin saturation. And of course, you should also consider the adequacy of cardiac output. You should consider the adequacy of the lactate production. So there's a set of different measures. And on these 4 steps, increasing circulating volume, increasing venous return, increasing cardiac output, increasing peripheral perfusion and oxygenation, I should always ask, do I need it? Do I have parameters supporting me that I do need to do this? And should I do something with it? And is fluid the best solution?
Thank you.
Okay, and you cannot see me, I'm János Fazakas.
I see you. Hi.
Okay, hi. So I have a comment on albumin, because if we give albumin in oxygen depth condition, high lactate, very high lactate, the albumin will cause netosis. So this is why it's prohibited to use it in this condition, only after you paid back the oxygen depth first. The second, the most important effect of the albumin is not only the colloidal one, but its buffer capacity, because a lot of cytokines and other bad molecules are attached to the albumin. And because of that, the glycocalyx damage will be less, because these bad molecules will not act on the glycocalyx. The third, I am 70 kilo, 5 liters of blood. Let's say my albumin level is 40, actually. Yeah, so I have 200 grams in my blood. However, the 2/3 of the albumin is outside in the interstitial tissue. So I have 200 in the blood, and I have more 400 in the interstitial tissue. So it's something normal that the albumin will go there to collect a lot of molecules. My question was to you that my hemodynamic view is that the hemodynamics are very, very heterogeneous. So what we do the monitoring in the thorax, indifferent what you measure, millimetry mercury, flow, or so pressure, flow, or whatever with the echo. And we believe that if in the thorax the intrathoracic blood volume, the cardiac output is okay, then outside of the thorax everything is okay. However, that is not true, because usually when we give volume, half 2/3 of volume will remain in the splenic area, in the skin, and in the lung as extravascular lung water. And when you measure again the hemodynamics with your monitor will tell you that the patient is also hypovolemic at the moment, so it will be force you to give more. And I think that because of that, we use sometimes too much volume. So we should check also the heterogeneity of the hemodynamic picture of the patient. And now we have the ultrasound on the side, so we should check the velocity of the other organs. And based on that, if they have a good perfusion, maybe the thoracic monitoring of the hemodynamics, it tells you that you should give more volume, but it's enough. What is your opinion about that?
Thank you, Janusz. I won't comment on the albumin. I fully agree with everything you've just stated. I will just comment on the last part, which is the relation between the central hemodynamics and the peripheral perfusion. Yeah, I just fully agree. The central hemodynamics does not necessarily translate into improved peripheral perfusion. And this is the target of the resuscitation. Peripheral perfusion is the target of the resuscitation, not a number on the hemodynamic machine. That's just an information helping me to do the last step. The last step is improving peripheral perfusion. I'm not sure if the sonography of kidney and perfusion of kidney, or if this is our possibility to do in an everyday routine or even in a everyday resuscitation, like do repeated checkups of the perfusion, but we can still rely on the for instance resolution of oliguria. Okay, and if there is no resolution of oliguria, I can check the perfusion of the kidney, for instance. So that's one of the possible steps we have with echo. And opposite, we can use echo in terms of the accumulation, in terms of the further steps of the treatment, to look whether we should not remove fluid. So echo is definitely a good device to use. And I definitely support what you said and what Joel said. And I just stress up, that's the peripheral perfusion. The information from the central hemodynamics is important information for me. Without the peripheral perfusion, with only the information about the peripheral perfusion, it might be more difficult for me to modulate the central hemodynamics, to distinguish between inotropes, vasopressors, fluids, etc. This is where it helps me, the hemodynamic monitoring tool, but it won't help me in the last step. I need something more for the last step.
Thank you very much, Jan.
Thank you.
I think it's a very important message in this field about the fluid resuscitation and the sepsis. Thank you very much for being with us, and we wish you a very nice day for today. I'm sorry, I know that it's a very hot topic and we have a huge amount of questions, but the time is running, so I would like to call Zoltán, who will talk. Hi, Jan.
Thank you very much, and greetings to all friends in Budapest.
Thank you.